Good afternoon, ladies and gentlemen. Greetings from Hong Kong. Thank you for inviting me to talk in the 2021 Asia Pacific Cardiovascular Intervention and Surgery. First of all, I would like to thank the organizing committee for the kind invitation. I was asked to talk on how to evaluate small functional right ventricle with significant tricuspid regurgitation, including Epstein anomaly and pulmonary atresia with intact ventricular septum. In the scenario of right ventricular hyperplasia and tricuspid regurgitation, apart from its association with the two lesions as mentioned, can also occur in the setting of other congenital heart disease, including ventricular septal defect, tetralogy, complete atrioventricular septal defect, transposition, as well as the double outlet right ventricle situation. For this talk, I shall perhaps focus more on the pulmonary atresia with intact ventricular septum and Epstein's malformation. Of course, we've been seeing patients with either small right ventricles in association with the pulmonary atresia condition, or a small functional right ventricle in the settings of Epstein malformation. And in approaching these patients, we always asked the question of whether the subpulmonary right ventricle is adequate to support the right-sided circulation. And of course, it has important clinical implications on the adoption of either a univentricular, 1.5 ventricular, or a biventricular approach to repair. So the first logical question would be, how should we evaluate the adequacy of the small functional right ventricle? We should, of course, consider the morphology of the right ventricle and also importantly its size. Additionally, we should also assess its physiology and function, in particular the systolic and diastolic function of the functional right ventricle. So how small is too small? This is not an easy question to answer. Animal study of Fontana operation by Yiu-Fai and colleagues years ago suggested perhaps that the right ventricular size of 30% or less does not contribute to cardiac output. And follow-on human studies of congenital heart disease suggest perhaps that using a tricuspid valve score, Z-score, as a surrogate marker of the right ventricular size may be perhaps a useful indicator. Mark de Lavelle, years ago in London, have suggested that in patients with pulmonary atresia with intact ventricular septum, a tricuspid valve Z-score of more than -3 can probably be incorporated safely in a complete biventricular circulation, whereas those less than -3 cannot sustain total pulmonary blood flow. And in the United States, the Congenital Heart Surgeon Society likewise suggested the usefulness of the tricuspid valve Z-score as a surrogate of the right ventricular size, and similarly predicted a very low success of biventricular repair for patients with Z-scores of less than -3. And their data suggests perhaps that those with Z-score of -2 or above would predict a better biventricular circulation in these patients. Chowdhury and colleagues summarized the important factors to assess the adequacy of the subpulmonary right ventricle to sustain circulation, taking account of the size of the tricuspid valve, and additionally the right ventricular volume, morphology, as well as the right ventricular outflow dimensions. As you can see here, once again, based on the assessment of the tricuspid Z-score, or its ratio of mitral valve diameter, the volumes as assessed either by echo or cardiac magnetic resonance, the echo assessment morphology and the cavity would have implications of whether the patients would have successful biventricular repair, and for those with extreme end of the spectrum, with that score of tricuspid valve less than -5, volumes less than 45% of expected, unipartite right ventricle, these patients would require single ventricular repair. So in terms of the contemporary criteria in the assessment of the adequacy of the subpulmonary right ventricle, whether it can sustain the pulmonary circulation, it will be important for us to assess the tricuspid valve size and convert it into the age-adjusted Z score, assessment of the right ventricular volume, whether by echo or cardiac magnetic resonance imaging. And apart from these measurements, it will be important also to assess the functional performance of the right ventricle that I should elaborate later. Well, the smallish size of right ventricle and its adequacy to support the circulation has been the focus of attention in patients with pulmonary atresia with interventricular septum. So what about patients' Epstein's anomaly? As perhaps been suggested by the title of this talk, that one will also be worried about the adequacy of the functional right ventricle in Epstein's malformation. However, as pointed out by previous publications, many people do think that functional right ventricle is small in patients with Epstein anomaly. But is that really so? Well, people tend to think that way because a possible explanation is the size of the dilated right atrium and atrialized portion of the right ventricle makes the functional right ventricle in proportion look extremely small. Well, interestingly, data, in particular those based on the cardiac magnetic resonance, suggest otherwise. So as you can see, this particular study by Fresh and colleagues have shown that patients with Epstein's malformation, ranging from adolescents to adults, basically do harbor significantly enlarged functional right ventricle, with majority having right ventricular volume more than 100 mils per meter square. The findings has in fact been replicated by other groups, for example those from United Kingdom, using the cardiac magnetic resonance based software to draw the meshwork of the right ventricle in patients with Epstein's anomaly. What you can see here, first of all, is the variability in the shape of the functional right ventricle, and from the table, once again, you will be able to appreciate really that the functional right ventricular volume, as measured by the end diastolic volume index and the end systolic volume index, is significantly greater than that of normal healthy control subjects. So once again, attesting to the fact that although by initial echo assessment the functional right ventricle may appear smallish in size, in fact the MRI-based assessment many times shows enlarged functional right ventricle. And that's perhaps the reason why in the surgical series, many times it's not the right ventricular volume, the functional right ventricular volume that matters. It's really the tricuspid valve that matters. And in fact, in this important paper by Dr. Da Silva describing his cone repair of the tricuspid valve, when asked whether he is always able to perform this technique, his answer is that, well, in the type D of Carpenter's classification, perhaps we have to go for valve replacement. Or perhaps in older patients, if you have difficulty finding tissue enough to construct a good tricuspid valve, it may indicate valve replacement or the Carpenter or the repair technique. In ASIC's experience, however, he said that all cases were done with the cone reconstruction. So, as you have heard, that he did not mention anything about the smallish functional right ventricular volume. And in fact, the important things based on echo imaging of the for the pre-op planning of Epstein's malformation include the right ventricular dilation, severe tricuspid annular dilation, absence or presence of septal leaflet tissue, the degree of leaflet muscularization, and also is important to assess the anterior valve leaflet, whether it is large and has a free leading edge. Once again, there's nothing really of concern about the right ventricular volume. Well, in terms of the assessment of the volumes of respective cardiac chambers in Epstein's malformation, indeed, it may provide some information on its associated parameters of heart failure. This is a newer index being proposed based on the MRI assessment of the right atrial volume, atrialized right ventricular volume, functional right ventricular volume, as well as the left atrial and left ventricular volume. Now this so-called the total right to left volume index, which is a ratio between the right atrial plus the atrialized right ventricular plus the functional right ventricular volume over the left atrial and left ventricular volume, did correlate with the indices of heart failure, including the BNP level, APCIS, tricuspid regurgitation, and the oxygen consumption exercise parameters. And this, when compared with the previously reported CELMI index, that basically included the functional right ventricular volume or size in the denominator rather than the numerator, correlated with less of these indices. So it is also important to assess the function of these various compartments in Epstein's malformation. Of course, we have different tools, echocardiographic-wise, and also MRI-wise, to assess the right ventricular systolic function by assessing both the fractional area change of the right ventricle, tissue Doppler assessment, strain assessment of right ventricular systolic function, and also there are tools to assess the right ventricular diastolic function using the conventional Doppler as well as the tissue Doppler technique both before and after operation. Apart from assessing the size, the function is important. Say, in these two patients, after respectively the opening of the right ventricular outflow by the radio frequency technique for pulmonary treatment with interventricular septum, and for the patient below after cone reconstruction of the tricuspid valve in Epstein's malformation, one fact to ask the question whether in the first patients the small stiff right ventricle would suffice the purpose as a subpulmonary right ventricle, and in the patient below, can this dysfunctional dilated right ventricle perform the same function? So it's important, therefore, when we assess these patients, not only should we assess the adequacy of the size of the right ventricle, we should also try to assess and predict what might happen to the right ventricle in the long term. And in fact, long-term studies do suggest the importance of the late right ventricular function, as in our previous studies showing that in patients after repair of the pulmonary treaty of interventricular septum, they do suffer from restrictive right ventricular physiology, increased in late gadolinium enhancement of the right ventricle suggestive of myocardial fibrosis, as well as atrial dysfunction, increased in the central venous pressure. In patients after biventricular of Epstein's anomaly, colleagues from Great Ormond Street Hospital also shows continued impairment of the right ventricular function in patients after biventricular repair, cone reconstruction of the Epstein's anomaly. So far, we've been focusing on the right ventricle in terms of its size and function. Of course, it's important also to assess the tricuspid valve in these particular contexts, given the associated tricuspid regurgitation and also intrinsic malformation of the tricuspid valve. So, with the advancement of the echo, not only the two-dimensional but the three-dimensional and transit-physiology echo has now allowed us to assess in detail the morphology of the various tricuspid valve leaflets. There are defined criteria to assess the severity of tricuspid regurgitation, be it using the diameter of the inferior vena cava, the jet area, and also the continuous wave Doppler signal. In the assessment of tricuspid regurgitation Epstein's anomaly, I would like to caution about the use of some of these parameters, as the hepatic venous systolic flow reversal may not be evident in Epstein's malformation. The assessment of vena contracta may be difficult, and also it may not be achievable to measure the proximal isovelocity surface area. So many times rely on the width of the vena contracta and also the coaptation gaps in patients with Ebstein's malformation. Now, recently, Dr. Marina Hughes from Great Ormond Street Hospital has suggested the measurement of a relatively simple index, what she called the Epstein valve rotation, and which may give us some prognosis to the feasibility of the surgical cone reconstruction. Now, what you are seeing here is basically the group used the right ventricular long axis from the cardiac magnetic resonance imaging. That is the plane of the systolic apposition of the tricuspid valve leaflet. And the angle was measured between the first axis. So the first axis is between the right ventricular AV, right atrial ventricular growth towards the fulcrum, and the second axis from the fulcrum through the systolic plane of the valve coaptation towards the right ventricular free wall. So what you can see on the right side is that there is a correlation between this angle and the severity of the Epstein's anomaly based on the Carpentier classification, and more importantly, for those patients with a very increased, very large angle of rotation, basically it is associated with a higher risk of cone dehiscence versus those with a smaller Epstein valve rotation angle with a better prognostic postoperative outcome. So hence, in the assessment of the tricuspid valve, it is important not only to assess the various valve leaflets by three-dimensional echoes nowadays, or even transesophageal echo, to assess the anterior leaflet, the septal leaflet, posterior leaflet, and additionally, based on the MRI, pre-op planning should also include this relatively straightforward measurement of the Epstein's valve rotation. One should not forget that tricuspid valve abnormalities is well known to be present in patients' pulmonary atresia of intact ventricular septum. The majority of patients have restriction of the tricuspid valve apparatus with an underdeveloped annulus. Of course, during the management in the neonatal period or early infancy, seldom was the tricuspid valve tackled, and that the tricuspid valve regurgitation usually would improve with opening right ventricular outflow. Nonetheless, this severity of the tricuspid valve during the neonatal period, early infancy, do have prognostic implication, as you can see here from the Congenital Catheterization Research Collaborative. Data show that the greater degree of tricuspid regurgitation is associated with less need for catheter reintervention, and perhaps this may be related to the greater size of the right ventricle. So the assessment of tricuspid regurgitation early after birth in these patients would have prognostic implications. However, upon follow-up of these patients, we have, for example, looked at over 100 adult survivors up to 55 years after repaired pulmonary atresia with interventricular septum, and some of those after opening of the critical pulmonary valve stenosis. Moderate to severe tricuspid regurgitation is much more common in patients with pulmonary atresia with interventricular septum as compared to those with critical pulmonary stenosis. And furthermore, in another study published by a Boston group, showed that patients with pulmonary atresia with interventricular septum once again had more significant tricuspid regurgitation and required more tricuspid valve repairs. So in due course, when these patients become adults, we of course need to be meticulous about the assessment of the tricuspid regurgitation and to ascertain the need for tricuspid valve repair. So in conclusion, ladies and gentlemen, it is important in some of the congenital heart disease associated with the smallest of pulmonary right ventricle, in particular pulmonary atresia with interventricular septum, with perceived smallish functional right ventricular tricuspid regurgitation, as in the case of Epstein's malformation, to assess the right ventricular size, morphology, as well as the physiology and the function. It is important preoperatively to evaluate the adequacy of right ventricle, but more importantly in the long term, after the biventricular repair, to assess also the adequacy of the function of the right ventricle. It is important, of course, to determine the morphology and competence of the tricuspid valve, both serving as an indication and the approach to surgical repair, and the role of the echo, not only two-dimensional echo, but three-dimensional and transdisoptic echo, as well as the cardiac magnetic resonance imaging in the assessment of the right ventricular volume. The tricuspid valve cannot be overemphasized. So thank you very much for your kind attention.